Hello, it's nice to see everybody. C'est vraiment un plaisir d'être ici aujourd'hui. And I want to start by just acknowledging the land that we gather on today is the territory of the Algonquin people, and I feel very grateful to get to play and work here every day. So I'll get started, and hopefully you had a good lunch and nobody's going to be napping, though it is a little dark, so you could probably get a little bit of sleep. I just want to start with declaring the conflict that is behind me for accreditation purposes, and we'll get started. Oh, it just says Mahajan presentation. Do you guys see the same? I'll just start. So today what I'm going to talk to you about, as we talk about what we're grateful for, I'm talking about all of you, which is the greatest asset in the healthcare system. You're balancing many things and juggling many tasks, but there's also expectations that are huge. And the healthcare setting, as somebody who's worked in various workplaces and with various workplaces, the healthcare setting is very unique. It has unique, and not just the healthcare setting versus other workplaces, but each healthcare setting is quite unique. And I'm sure if I asked any one of you about how your workplace is different, it's quite diverse across the room. And these statistics you're very familiar with, so I won't go through them, and I'm sure you've heard a little bit about them over today and probably tomorrow. But when we look at Canadians, there's more than 500,000 Canadians that are not at work per week. And healthcare workers and practitioners and those who work in healthcare settings are 1.5 times more likely to miss work. And that's because of things like burnout, compassion fatigue, and sleep deprivation, and many others that we've talked about already this morning. Physicians in particular, but as well as nurses, more than 40% are reporting burnout. And a recent survey with 4,000 people, where they surveyed them, about 50% of them said that mental health or substance use, they were suffering from the illness. And 1/3 of physicians actually have no regular source of their own medical care. And this is a global epidemic. This is not just something here in Canada, it's all around the world. And I was actually in Australia not long ago where we were working on workplace mental health all across the country. And I actually was asked to go back to Australia, particularly for the healthcare system. There they were really struggling with specialized doctors, and they had huge rates of suicide and suicide ideation. But this is something that countries all around the world are struggling with, and there's in my introduction they talked about a national standard, which I'll talk about, but there's an international standard that was developed about a year ago, and that was 50 countries. And as I was sitting with that table, across the table, and there were 50 countries, every single country was talking about how they were struggling with this. And especially with COVID, that impact and that reality has become more and more. And not only did it add stress and pressure and demands, it added, I would say, unbalanced and much more stress, pressures, and demands in those who work in the healthcare field. So COVID took something that we knew a little bit about and really just brought it to the surface. And I talked at the beginning about the healthcare setting and how it's different and unique, and many of you know it, so I don't have to tell you. But these are some of the unique stress factors that we see in healthcare settings. Unreasonable and huge expectations, excessive workload, and also things rapidly evolving. I now work at Genome Canada, and I oversee all our research, innovation, and health. I cannot begin to understand how fast even that field is evolving. And the more and more that I'm working in healthcare with a totally different portfolio of AI and genomics, I'm like, how are physicians and healthcare workers supposed to keep on top of every single innovation, new technique, health records, new ways of recording? It's incredible, the expectations and the workload. There's also unique workplace hazards and a very unique employment relationship, no matter where you work in the country. And the other issue is that they're just not seeking help. With all those data that you saw before, a huge amount are not seeking help. And that's of varied reasons. There's been many surveys, and I think some of you talked about it this morning. It could be embarrassment for coming forward, especially if it's something that might be perceived as a mental health issue. It could be fear of the implications on your career. And also one big piece that I go to again and again will be stigma, which I'll get to in a moment. Today, my perspective or my expertise that I'm bringing is really focused around the psychological health and safety. I think physical, there's quite a good understanding. And when the panelists come up, we'll really look at all three, especially cultural, which I think is probably one that's a little bit more new and one that we're still learning about around these three. So when we talk about psychological, I think one of the biggest barriers for not seeking help is stigma. And when I talk about stigma, those are the behaviors and the attitudes that we have and why often people don't seek help. And that includes both structural stigma and self-stigma. And earlier I talked about a survey that was done with 4,000 people where 50% had come forward and saying they suffer with a mental health issue or substance use. Within that, 95% of people said they have felt stigma in the last 5 years. And 75% said a lot of that has to do with self-stigma. This is quite pervasive, and in our healthcare system, there's huge structural issues that are embedded in the culture that reiterate that stigma piece for healthcare workers. And I mentioned earlier, so when we were, and I'll go back to this around stigma, but when we look at why people aren't seeking help, why workers aren't coming to work, especially healthcare workers, one of the key things is around supporting mental health and wellness in healthcare settings and in workplaces in Canada. And so about 10 years ago, a national standard for psychological health and safety in the workplace was created. And it was championed by the Mental Health Commission of Canada. And actually our CEO, Michelle, is here today, an amazing leader in the field who spearheaded this work. And it's really a framework, guidelines that any workplace in the country can use to try to support, prevent psychological injury and promote the well-being. So about 10 years ago, this was done, and it's really based around 13 psychosocial factors. I don't know how big it is on your screen. It's actually quite small. But if you take a look, squint your eyes, and see the 13 factors, everything from civility, respect, to growth, clear leadership, organizational culture. When you look at these 13 factors and you think about your own workplace, or maybe a healthcare setting you've worked in, or maybe your own experience as a patient, are there certain workplace factors that come to your mind right away when you look at this list and you think, if I had one or two of these were addressed in my workplace, things would be so much better? Or alternatively, take a look at those factors and think, wow, that's the one thing that my workplace really needs to work on. And I can imagine that most of you in this room, even looking at this list very quickly and not really knowing what every factor means, can probably look at one of these factors and think, yeah, my workplace really could focus on this, or we're doing a really good job and that helps us. So the way the standard works, it's not rules, it's really an outline of what a process any organization can take to try to assess where they are around these 13 factors. These are the factors that a workplace can impact, and these are the factors that impact an employee's well-being. And the standard, what it does is it lays out a process that any organization can take to figure out where you are around these 13 factors and what you can do to try to really put policies, procedures, and processes in place to protect an employee's well-being. And you're probably thinking that sounds pretty simple, but it's been 10 years, it's been out there, and it really works. And when it came out, there were 4 sectors that used it the most in Canada: education, first responders, public service and government organizations, and healthcare sectors. And there was groups like Healthcare Can, and I know Jonathan Mitchell's here, and Jennifer Kitts, who's now at CMA. They were huge leaders trying to really push this in the healthcare system and bringing people together. And through time, it was actually working through with healthcare organizations across the country that 2 additional factors were put in because the healthcare sector is so unique. One is around the protection from moral distress. And that speaks to the psychological impact that healthcare workers sometimes feel because of their ability to not be able to control the level of quality of care they can offer, or how they can offer that care, or the continuous care. And the other one is support for self-care, is how much capacity does the organization allow for healthcare workers to actually support themselves and be able to do self-care. And the good thing though about workplaces, even though I said healthcare settings are so unique and even across the country they're so diverse, there's actually a lot of shared characteristics that actually have worked towards the healthcare sector being a real, I wouldn't say maybe the leader in this area, but there's actually some healthcare organizations that I've worked with have really been ahead. And I think some of these shared characteristics have helped that. A commitment to health, a very diverse workforce, and the piece around public accountability. So one thing the standard does talk about is the idea of it being a joint responsibility between the organization and as well as the people who work in the organization. So when the standard came out, the first question everyone asked us was, who else is doing this and does it actually work? There's lots of guidelines and frameworks out there. Tell us, why does this work? Now, first of all, the standard was the first in the world. And after that, other countries have replicated it. And as I mentioned, there's now an international standard. But when this came out, it was the first in the world. So people wanted to know who's using it and what's the impact. So the Mental Health Commission of Canada did a case study project where they followed 40 organizations, and half of them were actually healthcare organizations. Everything from a long-term facility to hospitals, community settings, to see how does this actually work. In one hospital, it was actually their motivation to do it. I mean, they wanted to do the right thing, but their real motivation was that they wanted to address absenteeism, particularly nurses' absenteeism. And that was also to save money and all the regular things that kind of drive organizations to move through this. So they worked with us for several years. And when we were doing some follow-up measurements to see, okay, did we actually get people to stay at work and did absenteeism go down? Of course it did. But actually what happened was medical errors went down, patient safety went up, patient satisfaction went up, and suddenly that hospital was one of the more well-known hospitals and actually got up on the scale of top 5 hospitals in some kind of list that they cared a lot about that I didn't know about. But the point was that it makes sense. If we take care of our healthcare workers, we think about their psychological, physical, and cultural safety, we can offer better healthcare. And that's what we see every day in the news. Everywhere we work, we're hearing all the time about the healthcare system. And actually, I heard a really interesting thing the other day. Someone said, I'm really irritated when people say our healthcare system is broken. It's actually working exactly how we planned it to. The problem is, did we plan it properly? Are we funding it properly? And are we focusing on the right things? So when we talk about the healthcare system and it really working the way we want it to work, I really believe one of the most important components of that are the people in it. And I always put this slide in my presentations because I've been working with workplaces for many years in this country and abroad, and often people go and they write strategies. They put in little pieces of things. Maybe it's training, a one-off training, or maybe for some people it's a lunch and learn or yoga or whatever it is, these little pieces. But culture will always eat strategy. And in healthcare, to me, this is a really important thing. Culture is so embedded in the health system, whether it's in the education when you're going through medical school or your residency or your fellowships or the different settings you work in. There's a very deep-rooted culture. And we need to work on fixing that as well as thinking about broad strategies. I think a big piece of that is education, literacy. These are the things that have shown to work in healthcare settings. But changing the culture, making sure your leaders and your managers are trained, understand, are accepting, that we actually understand the stigma and work to break it down. And there's many effective programs out there. But that's what we need to work on. These one-offs or little pieces aren't going to change it. We need to really think about changing the culture and not just looking at the psychological piece, but the physical and the cultural. So I'm going to end a little bit early because we wanted to gain some time back. But obviously, just to say, looking at the psychological health and safety, as well as the physical and the cultural, there are many, many reasons for doing that, and it isn't always just for the bottom line as people want in an organization. And so I will leave you with this question as we move into our panel, is can we really have a health system? Can we really address all the problems that we hear in the news and in the government around our healthcare system if we don't prioritize and really work at our psychological, physical, and cultural safety of our healthcare workers? So thank you. And I think Adrian's going to come back up and introduce the panel. I'm going to get my notes.
Thanks so much, Sapna. Now it's my pleasure to introduce our panelists. They will each take a moment to declare any conflicts of interest. Dr. Franco Rizzuti is president of the Canadian Association of Physicians with Disabilities, where he's spearheading initiatives to increase inclusivity in the workforce. He's a public health and preventive medicine specialist working as a medical officer of health for Alberta Health Services, and is a past president of the Professional Association of Resident Physicians of Alberta. Dr. Rizzuti.
Thank you so much, Adrian. And for CME accreditation purposes, I have my disclosures. They should be behind me.
Not yet. Now they're there now.
There we go.
Okay, thanks so much. Philip Stack is Director of Health, Safety and Environment at the University of Alberta and has more than 3 decades of experience in healthcare and higher education. He's creating a people-focused culture for the institution's 14,000 staff, incorporating trust, accountability, relationship building, and safety into all activities. Philip also served as co-chair of a working group at the university that developed a 3-year safety action plan focused on ensuring physical, psychological, and cultural safety in the workplace. Welcome, Philip.
Thank you. And pursuant to the CME declaration, you'll see my conflict of interest declaration behind you.
Thank you.
Behind me, in front of you.
Thank you. And Dr. Nell Wieman is Acting Chief Medical Officer at First Nations Health Authority in BC and holds the distinction of being Canada's first female Indigenous psychiatrist. Recently, Nell co-chaired the Provincial Technical Committee that created the BC Cultural Safety and Humility Standard, the first of its kind in Canada. It provides a toolkit for the BC health system on how to address anti-Indigenous racism. Dr. Wieman.
Great, thank you for having me. And for the purposes of CMA accreditation, my declarations are in front of you as listed.
Thank you. And Sapna Mahajan will be moderating this 30-minute panel. So Sapna, over to you.
Hey, thank you. So we'll just jump into it. It's a bit of a fireside chat where I'm going to ask the panelists some questions and we'll go back and forth. So I haven't actually told anybody what order or any of this, so I'm just going to surprise you. But the first question, you heard me talk about psychological health and safety today. I know often organizations will start with physical health. And so maybe my first question, I'll go to Philip. I know in our prep call, the University of Alberta has been doing quite a bit of work in this, but really was focusing on physical health and safety. So my question for everyone, but we'll start with you, is why include the psychological and cultural aspects to it? Why did you specifically add that in what you were doing?
Sure. Thanks very much, Sapna. So the University of Alberta, unfortunately, had experienced a series of very serious reportable and near-miss incidents. And as a result of coming out of COVID, we felt that people's health and safety practices and so on had lapsed considerably. So we knew we needed to deal with physical safety, but when we first got into it, we very quickly realized you cannot create a physically safe environment if you at the same time don't deal with psychological and cultural safety. If an individual feels intimidated, threatened, bullied, harassed, they're not going to come forward with health and safety concerns. They're not going to come forward with and report incidents. And the same thing, if an individual isn't free to express themselves, whether that be from their in terms of their background, their sexual orientation, their religious background, etc., again, if there's that level of discomfort and so on, they're not going to come forward either. and deal with safety issues, of which psychological safety and cultural safety is critical. So we very quickly shifted and realized that in developing the culture of care, our 3-year action plan, we've got to deal with all 3 aspects of safety, and that's what we're doing, and we hope to implement. And to the comments earlier in the presentation, really focus on shifting the overall culture of the University of Alberta. And it's only through that shift in culture are we truly going to get to all 3 aspects of safety.
Very good. And Dr. Wieman, maybe I'll go to you next. If you could offer a little bit of the importance of not looking just at the physical piece, but the other 2 aspects.
Great, thanks, Sapna. I think before I start, I just want to take a moment to acknowledge that I am an uninvited visitor to the Algonquin territory and just pay my respects. But I think just to add to the conversation, I think from an Indigenous, or in my case, a First Nations point of view, and where I work in British Columbia, the aspects, the psychological, physical, and cultural safety aspects are sort of, you know, they're linked. It's obvious that they're linked. It's a very holistic perspective. And I think as a starting point, and I hope as we're having this discussion and including you sitting in the audience, that for me, when we talk about cultural safety, for example, cultural safety is the outcome in some ways that we are aiming for. And we have to have those hard discussions and acknowledge the hard truths of what Sapna, for example, was touching on in her keynote around medical culture. Medical culture, the medical system is based historically and in contemporary times in white supremacy and in racism that has excluded systematically Indigenous people, Black people, other people of color from participating. So when we're talking about creating safer workplaces, that means for everybody, but also when we have safer workplaces, ultimately what we all want is safer care for patients.
Thank you very much. I'll go over to you now.
Thanks, Sapna. So I'll think about this from 2 lenses. So the first is that as I reflect back to being a medical learner not that long ago, there's an incredible power dynamic in medicine. And if we think about physical safety, psychological safety, we can't really do that until we make explicit that implicit culture of medicine, until we start talking about what are the norms, what are the unspoken rules, and that comes back to culture. And so I think it's really important that when we think of it as a building that pipeline of medicine, you know, we need to think about culture. And then I'll look at it from the perspective of physicians living with disabilities. And I'd like to think about it about access and accessibility. Let's not talk about what people can't do. Let's talk about what they can do. Let's talk about their abilities. And when we think about that, medicine is incredibly ableist. If we look at the setup of a room like this, if we look at our medical schools, let's think about how could someone using a wheelchair get around? How can someone with low sight participate? And we need to really challenge that culture. And so if we're only looking at physical accommodations, we're only scratching the surface. And so I really do think we need to take that comprehensive approach to move the needle.
I like that, the pipeline of medicine. And I do the power dynamics is really important, and your piece around cultural safety being an outcome. That really resonates with me. That's why the 3 circles, I'm still trying to figure out how they're connected. And I know CMA's been doing a lot of work on it, but it's not so easy to figure it out. They don't just overlap. So even though you're focusing on can and cannot do, one of my questions would be, and we'll start with you then, is what are some of the challenges that is preventing us from really moving this forward, or for healthcare workers and settings to really move this forward?
Thanks, Sapna. I think, you know, we've made some great progress, right? We can't look at what we still need to do without recognizing all the great work we've done. If we look at admissions, if we look at the diversity in medicine, we've made amazing progress. But the challenge is we then have folks in the system and they're faced with structural barriers. They're faced with aging infrastructure barriers. And we talk about, you know, needing to move forward, and it's always on an accommodation basis. It's always on disclose and we will provide something for you. Well, let's flip that. Let's actually think about how do we move to principles of universal design, universal accessibility. And so the big barriers always come down to money, or it's not prioritized, it's aging infrastructure, that's somebody else's problem, that's a health authority problem, or it's the hospital problem. And I think we really need to think about how do we bring these players together? How do we, identify these key priorities and principles we all agree upon, and then we move forward from that.
And roles and accountability, which everybody has a role, I think, in this, and clarifying that is important. Philip, anything you want to add around that? Some of the barriers maybe you've experienced as you've been trying to push this forward at an organizational level?
Sure. The University of Alberta is a large, complex organization, like many of the hospitals and health facilities that you all work in. And so from our perspective in terms of moving the culture of care forward, there were immediate barriers that we identified. To be frank, there was a lack of leadership, of senior representatives, senior leaders across the organization, understanding what their role and responsibility is to drive culture change and to set an example of what a safe organization looks like. As Franco talked about, like in healthcare, there are also huge power dynamics across research-intensive universities between employees and the principal investigator, the graduate student, and obviously within our health science faculties. We've got to address that issue. We've got to address accountability, and we need to hold people accountable. This isn't about a stick. This isn't about pointing fingers, but we do need to hold people accountable for the outcomes and how they perform and interact and create that safe environment. Thirdly, we need better reporting. We need to understand how we're performing, where are the areas that we need to address so that we allocate our resources effectively. And then finally, we need to reward good behavior. We need to reward excellence. We need to reward best practices and acknowledge those people that are being safety champions across our university. If we can start dealing with some of those barriers, then we're going to be able to shift the culture of the organization.
Not easy things you've identified there, especially the leadership piece. It's funny, when I've worked in psychological health and safety, I'll go into a workplace and they'll say, these are our statistics on mental health. They're like, so what do we do? What's the mental health intervention? I'm like, it has nothing to do with mental health. It's leadership, management. Yep. These are people, and a lot of what you're talking about, pyrodynamics, the solutions aren't what people say as being, it's good management, good people, and equipping them with literacy and education and the skills and abilities to do it. And often, whether it's healthcare or even outside of healthcare, we constantly put people in leadership positions who actually aren't leaders and shouldn't be managing, or we haven't given them the training, the skills, and the support they require to do that in a way that's right. So I jumped in when I shouldn't be, but I just feel passionate about that. Dr. Wieman.
Yeah, I think to this section, the only one of the things I'll add is just, recognizing that conversations around cultural safety, systemic racism, and different forms of racism is a very difficult conversation to start and have. And I recognize people's discomfort, because I think at an individual level, people are like, well, I'm not racist, or I'm not trying to be racist. But I think what I'm trying to get at, and what you're going to hear a little bit more tomorrow in my colleague's presentation around unlearning and undoing white supremacy and anti-Indigenous racism, is we all in medical culture participate in a system that has racism built into it. And so I think in order to become safer, we need to, first of all, recognize that discomfort. And unfortunately, many people have to kind of sit in that for a little while and be able to listen to the truths that we are trying to share with you. And for example, when I was the president of the Indigenous Physicians Association, we supported some UBC medical students to do what they called the TRC report card project, Truth and Reconciliation. And briefly, what it did was they surveyed all the Indigenous medical students and residents in Canada and asked them what their daily experiences were as learners in this system. And what we found was, even though the medical schools at a very high level, at the level of the deans and the highest administrative levels, they had great documents, you know, saying we're on a journey of reconciliation, and that's terrific, that's good work, but it hadn't and it hasn't yet translated down to the everyday experience of Indigenous medical learners. And so that's where some of the work needs to happen. So we have that commitment to move things forward, to making medical education a safer place. But we still have to enact some of those changes so that it's experienced by Indigenous, and I'll also advocate for my Black colleagues who are learning in this medical culture.
It's interesting what you said, when people are often defensive and the first thing is, I'm not racist, but in the end, because the structures are there, if you're not actively undoing and unlearning, then you're contributing to it, and that's really hard because you're still working in a system that is that. And I think you're right, you have to become uncomfortable on the cultural piece, and I think that's why people are struggling the most. If you look at those three circles, 20 years ago I'd say psychological, people were resistant, not understanding. I think people understand that a bit more in the mental health. It's I would say it's becoming more, but I find the cultural piece, and we're revising the national standard right now, we've hit 10 years, and the number one thing is the equity, diversity, inclusivity, all of that is completely lacking. And we're sitting around the table, we don't have the right people around the table, and we're all sitting there thinking, where do we start? And so I guess one of my follow-up question then would be, when you think of organizations across the country, especially on the cultural piece, what are some things or solutions or best practices that you've seen or that you look at and you think, okay, they're going down that journey the right way? Dr. Wieman, sorry for you to start.
Well, I guess one of the things that I'll try to keep my answer brief again and allow for my colleagues to also participate is to point people to the BC Cultural Safety and Humility Standard, which actually deals with anti-racism at a number of different levels. And you'll see what we did when we created that standard was the work of undoing and unlearning and eliminating, in this case, anti-Indigenous racism happens at all levels of an organization. So one of the domains of the standard, for example, is governance and senior leadership. And we do, we have recommendations about how to be more inclusive of Indigenous people at the highest levels of senior leadership of health and social service organizations in Canada. For example, everyone here is aware there's all these new medical schools that are coming, that are being developed, the one in Toronto and the one in British Columbia. And right now, Simon Fraser University is searching for the first, for a founding dean. And I'm thinking, wouldn't it be incredible to have an Indigenous person to fill that role? And I say that saying, obviously that person is qualified. I don't think anybody's thought should go that they're not qualified, but we haven't had an Indigenous dean of a medical school in Canada's history. Here at the CMA, you just had your first Indigenous president. So that is one domain, for example. And then the other one I'll just touch on just super briefly is around the comments around equity, diversity, and inclusion. That is not sufficient, and anti-racism leading to improved cultural safety is related but separate. So there was a very interesting study that just came out within the last week or two around diversity is happening, but if you have more diversity in medical schools, for example, and within the medical profession, that doesn't mean that those people are not adequately supported and that they don't work and learn in safe environments. That infrastructure needs to be there, and so the standard speaks to different ways that can be operationalized.
Thank you. Thank you very much. I'll go over now maybe to Philip and then to you around when we think of healthcare settings and practice environments, and a little bit to the point is, how do we create that culture of cultural, psychological, and physical safety? And not just why it's important and the barriers, but what are some practices, and I love that you talked about people, that's so important, but what are some other solutions, and maybe in the work that you're doing that's really worked?
So we're early in the journey. We have 42 initiatives that we want to implement over 3 years, and we're moving those forward. But some of the examples, and none of this I think is going to be earth-shattering, but I think we're hoping that they're going to be effective. We've developed a toolkit for our senior leaders to provide them with the tools of what it means to be a safety champion and how they have to demonstrate leadership. And making sure that they know what their roles and responsibilities are, but we provide them the tools to be that effective leader. One of the most effective things that I have found, and it only takes 3 or 4 minutes at the start of every meeting, is safety moments. And just you present, I have attended several or participated in some dealing with the issues of our history and our culture and our unconscious bias. And I was shocked at the things that I learned and how I have that unconscious bias all the time. And all it takes is 3 minutes at the start of a meeting, and I have found them to be very, very powerful. The other thing is just communicating that it's a shared responsibility. It's not just about the leaders, it's about everybody's responsibility. We're trying to get to a stage where everybody owns their safety performance and that of others. And what that means is that individuals feel comfortable and confident. If they see an unsafe condition, an unsafe behavior, someone acting in an inappropriate manner, they know that they're going to be supported by the organization to intervene in an appropriate and professional manner to address that situation and stop that unsafe behavior. And it's through small steps like that that I really think we can make a difference.
Yeah. Dr. Rizzuti?
Thanks. Similarly, I'll speak to 2. And so the first, I think, is a small step that I've seen teams do, and it's similar to these safety moments, but it's checking positionality and doing a quick temperature check at the beginning of a meeting. It takes a minute. If you're in a Teams meeting or Zoom, put in an emoji that represents how you're doing. What did you do over the weekend? It creates that safe space to level set and say, oh, maybe someone just is having a rough day, and this isn't the time to engage in additional conversations. It's normalizing that culture of safety and just not jumping right into the business of the day. So it's these little things like that that really do shift culture. The second piece is I think we're starting to have some brave conversations. We're finally, after 30 years, looking at the technical standards for medical school admissions. You know, this was a document that said functionally you needed to be able-bodied to practice medicine. Well, we know that's not the case anymore. We can practice and deliver safe care virtually. We have a variety of accommodations that are safe. We know this works, and yet we have a document that's almost 30 years old that we go back to as, no, this is what the technical standards say. So we're having conversations to address that. And I have to give credit to a lot of our learners. Our learners have been the change agents and drivers here. They have been consistently 10, 15 years ahead of the profession. And so I think it's really continuing to support our learners, advocating, raising their voices, empowering them so that we don't lose that momentum that they've built, that they're championing. And so again, really do want to give credit to the learners. I think they've been leading this drive. The profession is finally catching up, but I think there's still a lot of work to be done.
Yeah, it's the learners that are going to champion this change over time. And I know many of them are in the room today. That's what I said when I came in earlier. I joined some of the sessions this morning. I was like, there's so many young people. Maybe I'm getting old, but I was like, there's so many young people. And I was like, that's the change, I think, when we're talking about this. You're seeing actually a lot of the leadership in different places in the organization. So one of the things when I go to workplaces and we talk about psychological, physical, and cultural safety, the thing I think people struggle the most with is the measurement piece. And how do you know when something's working, and how do we measure this, and what does success factors look like? And obviously we have a grand vision of the most idyllic station, way we'd want it to be. But as we think about these steps, and it's a journey, it really is a journey, not a destination. What are some of the success factors, or some of the things that you would hope to see if we were able to create this kind of safety culture we're talking about? Maybe I'll start with you, Dr. Rizzuti, and go across.
Sure. So I think to give a single, I think if we move to a place where medical schools, where healthcare facilities no longer need accommodations. It is universal access. And that is the foundation. Every meeting is accessible by design. Every virtual meeting has automatic closed captioning. If we have pieces like that in place that are automatic, I think we're moving to success.
It's great and very clear.
I think from my perspective, if when we see anybody, regardless of where they are in the organization, feel confident that they can come forward and express a concern or an issue as it relates to safety, that's a clear indication of success. We need to certainly look at things like the transparent process in terms of how we deal with these issues. And if the organization reaches a stage where it's confident that within appropriate framework is transparent in terms of how they deal with concerns, because we all know they're there. We know that unit, that department that has that underlying issue. When an organization is comfortable sharing actions that they're taking and so on in a positive way, I think that's another indicator of how you're doing. And then just as mentioned earlier, we know that safety is good practice. It makes for more efficient organizations, more effective organizations, more satisfied employees. When you see those indicators increase, I think you know you're heading down the right path.
Yeah. Dr. Wieman.
Yeah, I think the one thing I would add is that it's also important to look at qualitative data and people's narratives of their experiences. So we'll know that we are increasing the safety of learning spaces and workspaces in the medical profession when we see Indigenous medical students, residents, physicians, not just surviving their training, but thriving in the experience, being confident in who they are and where they want to practice, and being valuable contributing members of their communities. That was always my goal. We'll see people taking less leaves of absence from their training because of the burnout that they experience just from the weight of experiencing racism on an almost daily basis. So we'll have that kind of qualitative, I think, information. And I think ultimately, I guess I'll just end because I'm sitting at the end of this panel. Again, what I said earlier is we will see a safer medical system overall. And one of the reasons, when we talk about access, it's not just for Indigenous people, patients, it's not just having physical access to a medical service or a family physician. Indigenous people choose actively not to go to those services at this point in time out of a fear of how they're going to be treated. So we will know that we're creating safer spaces when we see access rates improve and people actually making use of the services that are available and ultimately being treated in a safe manner and achieving better health outcomes. So I think when we work really hard for ourselves to make the medical education system, the training system safer, physically, psychologically, culturally, actively anti-racist and dismantle systemic racism, we will have a better healthcare system by virtue of doing that.
Thank you.